Mark, just your take on genomic profiling or molecular characterization of tumors within the sarcoma world?
Yeah, so I think most of my peers would do quite similarly. So we send at diagnosis of metastatic disease, usually biopsy someone who has new metastatic disease, assuming that they had a disease-free interval from original diagnosis to development of metastatic disease, and send off the biopsied specimen. And then also, as you previously mentioned, some drugs can alter the ability for someone to go to surgery or for having a limb-sparing surgery. And so if someone has a stage 3 disease that potentially is incurable with surgery, we'll send off also at that point just to see if we'll catch anything that potentially is driving it.
And it's all next-generation sequencing that
All
you're using? Okay.
correct, all next-generation sequencing.
Marcia, in the thyroid world?
Yeah, so we do thyroid and head and neck. So, and one of the tumors we haven't talked about is salivary gland, because that's, of course, where we see the most of the tract fusions. So I've got two of the highest proportion ones. So in thyroid, mostly, of course, if it's metastatic, very similar to what you said. So I won't reiterate that obviously metastatic disease, if we don't know their profile, we get it. If we can, we try to get it on a new biopsy. But if they don't, I mean, it's not uncommon for a thyroid cancer patient to have sort of unbiopsyable disease, in which case we would run it on the original. Now, they don't usually have a lot of chemotherapy and other agents that might change it, so, you know, we can sometimes get away. It's probably not as bad as other cancers that get treated. But the interesting thing in thyroid is that there's two places where molecular testing is happening. There's a big development of panels that are being used at first diagnosis, because 90% of these patients will actually be cured. So those people are getting it because of prognosis and trying to push people towards surgery, or even more importantly, against surgery if they possibly don't need it, because thyroid nodules and even very indolent cancers are so prevalent. I'm pushing for everybody who has RAI refractory resistant disease to absolutely get tested. We also have very high actionable percentage, because BRAF by itself will give you 50% of papillary thyroid cancer. So by the time you do that, and then we have RET translocations, sometimes RET point mutations, and a few other actionable items, we're starting to push 60-70% in the metastatic world. So very high prevalence. And then salivary gland really has to do with people who haven't been cured. They're all getting tested, again, with NGS.
Ed, you want to round us out in the lung world?
Yeah, you know, I think it's kind of a debate in the lung world right now of doing everyone on a large platform, because there are those delays that occur 2 to 3 weeks, and I think people get impatient, especially when you have a very nice IO triplet that you can give to anyone without testing, which is both good and bad. What we do at our center is a reflex testing on an AmpliSeq profile, so we get that back in 3 to 4 days, and so we have everything we need quickly. Eventually, everyone does get a large genomic test, and we have a trial like TAPER right now that is a great study for us to encourage docs to test and find sort of a match there. So that we like to build it around that type of platform, but I do see the day, I mean, the writing is coming where up front, everyone's going to be getting a large-scale testing. Now, we've done that with blood, just as you have on one patient. I remember distinctly, we weren't as lucky to find something, but...
I thought I was so clever.
Yeah,
I'm just latecomer to the game again.
If you're not in lung, you're a latecomer.
And I actually I felt very sad when Philip was talking about the fine needle versus the core, because you know, in battle, this was our whole thing, was getting 2 cores, if not more. And this, I don't know where the resistance is coming from. I know it's some difficult tumor access, but there, somewhere in the interventional world, there is this resistance, even the pathology world, oh, don't call it an FNA, it's based on tumor cell content. Well, I'm just basing it on the needle size, I'm sorry, you know, size matters, okay, I'm sorry, but that, you know, let's just be frank what gauge we're using here and how many times you're making a pass and actually looking to see what comes out. And so the fact that we are still finding alternative, smaller platforms with easier access, which is the same as an FNA of what you're doing on the blood testing, which has a utility, but we still get more information out of the tissue testing. And I think we have to be very mindful and really stubborn about wanting to get that.
Yeah, I think when proceduralists, interventional radiologists, surgeons, or ask, how much tissue do you need? I say a boatload.
Yeah.
I need a boatload
As
of
much
tissue.
as you'll get me.
I think tissue still remains the gold standard. I'm encouraged by some of the plasma testing results that we're seeing, as well as some of the data that will be presented soon in Atlanta at AACR. Certainly, we've made a lot of inroads.